Buenas y saludos, bienvenidos todas y todos.
Good morning and welcome everybody to this Health Determinants, HIV and Activism on this HIV 2020 online conference. We're so excited to be here today. My name is Dr. Rafael Torruella, and I would like to start explaining how this presentation will be run. So first I need to notify that this presentation from HIV 2020, it's been recorded, and this presentation will also be available as soon as possible in the HIV 2020 website, as well as in the social media platforms in several languages. This presentation, it's been published on live through Facebook, as well as on the HIV 2020 website. All these virtual presentations on HIV 2020 will be offered in English, French, Portuguese, Russian, and Spanish. So please click in the interpretation button at the bottom of the screen, and then you will choose the language. In this screen, you will have the description on how this interpretation service is available. So we kindly ask all the panelists to speak slow and clear for the well-being of the interpreters, and they can handle and do a great job. As well, we kindly ask the attendees that they have their microphones and video off. If you have any questions, or in order to give any type of comments, please raise your hand, and if you are being chosen by the moderator of this presentation, then your microphone will be activated. Do not provide your personal information whenever you are asking questions if you feel uncomfortable about that. And this is related with the name, country, or organization that you belong to. Please use the Q&A session button to raise hand and to ask questions directly to the panelists, and then also you can use the chat box for any additional comments. You will be removed. Those participants who engage in such actions will be immediately removed without any further notification. So it might be possible that we cannot answer all the questions due to the number of attendees. It might be also that not all the questions in this selection of Q&A section can be answered during the period of this conference. So I kindly welcome you to these social determinants of health, HIV, and activism. These are the participation guidelines. So now I would like to open this panel. It is an honor for me to be here in front of these beautiful people. We will have several panelists today, and we will start with Mr. Charles King. Charles King is one of the founders and executive director of Housing Works. This is a community-based organization, a non-profitable organization that offers different integral services for people who living with HIV and other chronic conditions. Among the services offered, we can mention housing, physical health, mental health, harm reduction, problematic use of substances, legal services, vocational training, and activism. In the state of New York City, Charles has served in several working committees, such as in 2014 as community co-president of the group Para Acabar con el VIH-Sida in order to end HIV/AIDS, and now it's co-president of the committee to end the disease in the AIDS board. In November 2018, Charles was chosen to be part of the first working committee to eliminate hepatitis C in the state of New York. In the United States, he is co-president of this coalition, Act Now and End AIDS, a national coalition to end with the HIV disease. Additionally, he is in the directive committee of the National Coalition for Housing for People Living with HIV, and he has been involved in the directive committee of UNAIDS. He has a law degree from the Yale University, and he is a Baptist minister. So I give the floor now to Charles. Hello, everybody. In July 2012, Jim King, the president of the Global Bank opened the session of the International HIV/AIDS Conference held in Washington, D.C. In this environment, and this was the first time that the president of the Global Bank was in a conference like this. He had these strong roots in the AIDS community. He had founded Partners on Health, and both of them were in a certain level responsible to convince the whole world that antiretroviral therapy should be available in low-income countries. They had shown in the IT that the lack of formal education, the lack of water and roads didn't allow the non-compliance of these treatments. Besides, after 6 months of his charge, 1 month before, the bank will lead the path in order to eradicate extreme poverty for 2030. Within this opening lecture, promising that the World Bank will be committed in order to fight HIV/AIDS. But he invited the AIDS activists in order to create these alliances. On the next morning, animated by all these topics, a group of 6 people gathered together and met in the global village. They met in order to discuss how to assume this challenge in such a way that they can take advantage of the World Bank power and authority in order to promote the AIDS pandemic. So they spent 2 years working together, making the World Bank to be interested in the housing and other interventions, social interventions, without any success. In that sense, that will give us the opening that we needed. We also agreed that we needed to organize a summit between the World Bank as UNAIDS. Eric Sawyer and myself met. We were wondering with whom we should meet, and then our colleagues will speak with the AIDS Fund to organize a summit. So we spoke with them, and then they agreed that the World Bank would become the host of this summit and that the World Bank will be participating in it. In the meantime, Eric warned me that there was a vacancy in the civil society delegation in the governance committee of UNAIDS. So many people didn't know that civil society has 5 positions in the administrative board. Even though they don't vote, everything is decided by consensus, and they can participate fully in the meetings. Each position has a main delegate as well as an alternate. The alternate position for the North American section was going to be available, so I just was chosen, and in that sense we were really well positioned in order to move forward with the agenda that we had. In June 2013, Michel Sidibe, in that time he was the executive director of UNAIDS, announced that he was committed with UNAIDS to end AIDS as a pandemic by 2030, saying that whoever has the strength and courage to commit with the World Bank, then they can end extreme poverty by 2030, will become a coward if they don't commit themselves to do the same with HIV disease. So in that sense, that gave us more ammunition, because we cannot stop the disease if we don't speak about these other social factors. Finally, in January 2014, we held the first summit asking for action in order to have these social gears in order to stop the disease. The event was organized by the World Bank and was co-funded by PNLUD as UNAIDS and Housing Works. So experts from all around the world showed the current research at that time. And what we knew is that we can expand them and then that we need more research. Who, Sidibate and Helen Clark at that time was the administrator of PNUD, and everybody was there. So at the end, the World Bank and UNAIDS sent a communique, a joint communique, where they committed to adopt four joint action measures in order to promote this program. In this meeting of June, in the boards of directors meeting, they had a participation from the civil society delegation, and they spoke about this topic. And then afterwards, in the meeting in December, during the civil society organization meeting, they just implemented certain resolutions in order to cover those social factors within the meeting itself. After all those negotiations, it was not until very early on the next day that these decision topics were approved unanimously. So I won't read the whole text, but the key points are these. So the idea was to call the end of the HIV/AIDS disease, eradicating extreme poverty as well as inequalities, placing them in the center of the response to AIDS. Make a general call so the joint program of the United Nations reinforces the social protection programs and integrates these participations in the efforts of the citizenships. And specifically, these interventions that will then be financed by this development. Nutritional support, housing, education, employment, as well as economic empowerment as a counteraction to the critical efforts of these combination efforts on prevention and treatment adherence that reinforces and help people living with HIV, women and children, as well as some other vulnerable populations and other key populations. It is requested then to carry out more research on the interventions in order to face those social factors as well as economic ones to promote HIV, extreme poverty then, and inequalities. Finally, they were asking to have more participation and more involvement of people living with AIDS, MSM, sex workers, male and female, as well as some other people involved in the implementation of these objectives. The population of these decision-making bullets, then I promoted the high-level meeting to eradicate AIDS in 2016, held in the United Nations in June of that year. So in order to include these interventions to promote these social factors in the political declaration stated in that meeting. For the first time in this declaration on HIV, the fact that the HIV spread is a cause and the consequence of poverty as well as of those inequalities. So they were asking at that time that the responses to HIV and AIDS are fundamental in order to achieve the 2030 program for sustainable development within its three dimensions: economic, social, and the environment, where they recognize that this eradication of extreme poverty in all its forms and dimensions, including extreme poverty, then this is the greatest challenges at a world level, and it is an indispensable requirement for sustainable development. It is also recognized that poverty and bad health are extremely related, and that poverty can increase the spread of HIV towards AIDS. Services respond to sexual and gender violence at the same time that it highlights women and girls' vulnerability. It is also requested that services, housing services, education services, and employment services should be offered. So, in order that this UNAIDS organization, as well as the General Assembly of the United Nations, will lead in order to cover these social factors that promote HIV and poverty, represent important measures, but they are not enough. There's a lag. Since the last meeting of since the high-level meeting of the United Nations, they haven't given any step forward in order to implement any of these interventions. And it is true that none of them will lead these interventions in the scale that is needed in order to have a relevant impact in the course of this disease. And now, with this new pandemic, COVID-19, we're just requesting and we're just seeing that there are the same economic and social factors that implement and say who dies and who lives. So this is the reason of this. We need to find out new ways. We need to find out new ways on how to increase the topic of these social drivers of the epidemic. If we want to have a good and a remarkable result, we need to demand this action, this relevant action at all levels of government, as well as from the different international organizations that will sponsor UNAIDS, especially the World Bank and the PNUD. We need to insist that the Global Fund changes the path in order to include these objectives. So even in those richest cities where several advances have been done in order to achieve the objectives as a fast track, then we see that we are not achieving the same success for those who do not have a home, for those transgender people, and for those who were excluded from education as well as from those economic opportunities. So I hope that this conversation increases this topic in new ways. Thank you very much. Thank you very much, Charles. Thank you for your participation. Thank you for giving us that feedback on these social drivers and what is activism in the scope of work that we carry out. So now I would like to move on and to introduce the different panelists from different coalitions. So now I will introduce Stacy Velasquez. She's an expert in political incidents and human rights of people, transgender people, LGBTIQ+. She's co-author of Nosotras También. We too, about sexual violence against women trans, and co-founder of the Pla Transforma, Feminist Mujeres Somos Todas. She has participated in researches such as trans population in the midline of the Global Fund Guatemala 2017. She participates actively in the survey Centroamericana de Vigilancia y Comportamiento Sexual, and currently she is the executive director of OTrans RN in Guatemala and belongs to the Red Flag Trans, the Latin American network and the Caribbean of trans people. Stacy, good afternoon. Thank you very much. Thank you for inviting me. Thank you also to the HIV 2020 conference for considering and for considering these debates and these dialogues that are well deserved from this intersectionality, and that we can have, in that sense, this participation in these decision-making spaces. So I would like to start speaking about the Latin American and the Caribbean network of trans people. This is a Latin American and the Caribbean network formed by 25 organizations that we follow the same synergy. We have like a political agenda that is well defined. And in fact, we have developed a health guideline for trans people in the region that recently was launched in the HIV conference. But I think that these spaces also give us the opportunity to discuss about social drivers where the woman transgender population is vulnerable as a risk of HIV. So when we speak about these social drivers of health issues of transgender women, we speak about some human rights violations. We speak about also some of different contexts within many times they are imposed as the sex work, as well as the use and abuse of substances that makes that not feasible for them. And another situation that also it's related with these social drivers is the fact that there are no laws and public policies for women, for trans women. So in that sense, I would like to mention that when we speak about these social drivers, I would like to give you some data and some figures that we developed in Guatemala. And these results derive from this estimation on the status as well as on the size of the women trans population that was carried out in 2015. And here in Guatemala, the 71% of the trans women that were surveyed had suffered discrimination. 61% represent a low income below to the minimum wage. The 60% affirmed that they had suffered certain kind of abuse, sexual abuse, abuse from the police or their family members, and several different types of abuse. Then 50% didn't finish their local education, and between the 50 and 20 women are killed. So this is our reality. These are the social factors. These are the social drivers that are not far away from the reality of the whole region of Latin America and the Caribbean. When we see that the 80% of the government, of our government, they have a military guideline or Catholic and Christian fundamentalist and conservative drivers. So the rest, the 20%, it is in a latent threatening from these conservative groups, and they want to delete this gender identity law from Bolivia and some other actions of non-access to teenagers on this identity law in Chile. And those same people are the ones who are going against this. So all these factors are the social drivers that are related on the health of women trans population. So here in this country, we have more than 15,000 women trans people, and from them 24% of them live with HIV. That means that 1 out of 4 women trans live with HIV. And this situation, this is determinant. This is a social factor with regards of health, vulnerability, and risk. In that sense, we can say that we are 10 times more at risk. Why? Because the women here in Guatemala, we practice sex work, and 11%, for instance, live with syphilis. So these figures, this is the estimation that we develop in this research. So what do we need? What do we need in order to promote different initiatives that do not follow these social drivers? Let's say that these social drivers do not become a human rights violation. The idea is that these social drivers become, or these social drivers are created based on the strategies and the national health systems. But for instance, here in Guatemala, we have the integral and differentiated strategy for trans people, and it was approved on November 27, 2015. And after 5 years of being approved, this health policy, it has not been, it's not operative, it's not running right now. So we have worked with the government, and we have an international cooperation with civil society, but we are still facing several barriers for having this differentiated health. And this is also a social driver for our health. And this is for two reasons, because it is not the same to provide health services from a woman and from a trans woman. They have different needs. They have different variants with regards of health issues that for sometimes they want us to impose. They want to impose on us different things that lead us to not being related with the health system. For example, a trans woman that gets to a health service, they get the HIV test, they get condoms and lubricants, but they don't offer these mammal tests, for instance. They don't have like this integral health service for them. So I think that HIV has opened different doors in the health system. It is also the time that has to be transformed now. When I speak about a transformation, I speak about a transformation on the health services, because within this intersectionality, they have to include all these populations that are vulnerable and that we are involved in a different environment, which is completely different or which is not equal to that from the general population for this heterosexual population. So what do we need? What do we need as trans women in order to move forward and to move away from these social drivers of health issues? So that these social drivers do not represent any type of discriminative actions, or that are not related to any kind of non-liaison with regards of our health, and also that they do not represent any type of health violence towards our bodies, and being diverse and being different, and still we don't have access to sexual health and reproductive services. So they have been, in a sense, they had been categorized as within the HIV. So I want to close my presentation saying and going beyond that. I mean, it is true that we have this regional guideline, and this is a good practice that can be developed as a national policy in the 25 countries that belong to the Latin American and the Caribbean network of sex workers. Besides those guidelines, we also need a gender identity law. We need this identity law that recognizes our own identity, that also contributes to our integral development, that make them recover. For those women, for those ladies who had been affected by the disease, that do not have access to these tests, and also that do not have access to these preventive services. We cannot speak about resiliency. We cannot speak about that if we haven't spoken about how to restore that situation for them, because we know that it will represent a high cost for trans women with these constant social drivers of health issues, and also how to make them. Speaking about the law of Uruguay, is speaking about included all these factors, that they are not only giving this privilege, but they are also giving that compensation. And then all that fight is not recognized. So we need to do within the movement of HIV, this situation has to be compensated. Because we have discussed immense cases, international cases, and some of them had not been recognized and had not been compensated. So, and I'm speaking about colleagues, trans women, and this has to be included in the HIV. Also, eradication of violence and HIV has to be included within this law. And Also, I would like to speak about some of the vulnerabilities that trans people have, and that is the early expulsion of the house. What does that mean? When they acquire HIV at, let's say, 14 or 15 years old, they were left behind, and then they need to practice sex work at 12 or 13 years old. So this is what an early, and when we do not have like a government that really gives support to those needs, I can say that speaking about young people within the HIV topic, it's really weak. And I know that there are trans women that are detected, that they know that they have HIV at 24, but they knew that they acquired it maybe when they were 12 or 13. And then this is not covered for this type of population. And this is not us to blame to, but it is the lack of opportunities, it is the lack of public policies, and it is the lack of laws, as well as the lack of attention and care that cover the needs of this population. So these are the vulnerabilities. Also, gender, family, and social, as well as institutional violence and discrimination. This is something that we need to consider. Nowadays, in this Latin American and the Caribbean region, institutional violence, it's being regulated, it's being normalized. If they are going to choose a president, so we need to be against the human rights of the LGBTIQ population. If the ministries were going to be chosen, then the ministries who are there, they need to say that they are against. So we have become this barrier in order to create votes, but not to compensate our needs. So I think that this is something that we need to consider. From the HIV movement, it has to be considered also, because we need to consider this lycism in all the states. So, and we need to include that. We need to talk about that. Sometimes it is difficult for them to speak about sex work, and we cannot delete it, because in that sense that will represent that we will erase and we will delete several lives. Lives are lost. We lose dignities, we lose our childhood, and this is invaluable. So what all the states can and the governments can include within all these social drivers, it will be really helpful and useful that this situation is not so robust with regards of the violence to the trans woman. The health education, the more illiterate we are as trans women, it will be difficult to reach those figures of the World Bank on development. It will be difficult for us to reach those figures in order to have access to work. Speaking about also labor opportunities from the state and the government, they just only offer these opportunities as sex work. And in that sense, these are work offerings that are not, these are informal work opportunities. So we need to make them, we need to create more formal working opportunities. And this is also related to the low level of inclusion that we have in the health system. I would also like to highlight and to recognize the work done by all the colleagues that are members of the Latin American network of trans people, because it is really difficult to have the 25 of them here in this webinar, because it is difficult. But I think that from all those voices and from all those trans women that are demanding and that are fighting, greetings and the recognition to all their work and their activities from all the colleagues that are sharing this space today. it is very valid, and we also need to recognize the work of the regional secretariat, Mrs. Marcela, and I think that this is a political posture that it's coming together based on the work that we do, and the effects or the outcome is to reach and being able to speak about this topic, to speak about the epistemology of trans women, and to customize this in the Latin American context, because within all this fight, of course, we have this colonization. Trans women also need to be included in these working activities. Our community experience has to be recognized, because sometimes the clinical or the academician experience is being recognized, but they don't recognize the community labor that we do. We are still the cheapest labor, and we are not these testing animals. So we can demonstrate before and after these studies. So it also calls my attention that the 093 HTTNP that has been published, and I appeal to that, because it is not possible that at 12% of 47,000 that were included in this research, only 12% were trans women, when we have seen that it's difficult to reach those health services for this population. Another remark is that these studies are done always when they have a sustainable development. So in the region, in the Central American region, those studies are not held there. And I understand because it is related with two things: with the political will from the governments, as well as on the sustainability of the programs where these clinical essays are done. So if from these mechanisms, from the UNAIDS, from the World Bank, and so others, if the United Nations system, if we pressure them, and if they pressure to these governments, they can make that these programs become sustainable. So in that sense, I think that they need to make that risk in order to reach the international population, so they can invest more where this growth is not sustainable. But we as activists are fighting, so in a specific way, they are not discriminated. So far, this is what I have to share with all of you. So thank you, Stacy. Thank you for being here. Thank you for being you. Questions will be answered later. Our next speaker is Cynthia Navarrete. Cynthia Navarrete Hill. She's a Mexican woman sex worker, user of psychoactive substances. Cynthia was born in Mexico City and has technical studies on handling new technologies for communication. She belongs to the civil association APROACE that was formed in 1985 and was run by women sex workers, Mexican women sex workers. And since 2005, it belonged to the board of directors as a beginning as the general secretary of Treasury, performing actions as activists on human rights, labor, and of health in the working women. Since 2015, he is in charge of the general direction of APROACE. She carries out political incidents in order to achieve the inclusion of people that practice sex work in the board meetings and on the decision-making committees, Nada para nosotros, sin nosotras. She has participated in different forums and congresses on HIV and other STIs, as well as at a worldwide, regional, and national level. And currently, she implements visibility and strengthening activities from the plappers through different regional and global projects. This year, she was chosen as regional representative of the Organization of Sex Workers in Latin America before the NSWP, and she has decided to break her confidentiality as user of psychoactive substances, and she integrated to the LANPUD, the Latin American and the Caribbean network of people who use drugs, in order to be part of this organization aiming to increase her knowledge and to contribute in reducing the violent actions that people, users of psychoactive substances live in sex work, and to visualize the housing and lessons learned as user among her peers. Thank you very much, Rafael. Thank you for inviting me. Thank you for inviting me to participate in this forum and also to reach our voices and to share our experiences with everybody through this HIV 2020 platform. This is a new modality. At least here we are not using, or we don't need any visa, and that makes it more inclusive. But as this is new technology, what we have identified is that there are certain barriers in order to understand these new technologies also. Without a doubt, this is a topic that we need to be trained, because it is part of, it's an important element as activists. It's an important element for us to participate in these strategical spaces. However, most of my colleagues and most of my peers that practice sex work and many other people that are users of drugs do not have internet in order to participate, or in order to be able to participate in this type of forum. And that's an outcome of the poverty that we live in. And many times these voices remain in silence. So I am a sex worker since I was 25, and I have practiced and I work in different spaces. And as you know, sex work is carried out from different spaces, different areas. It could be bars, massage houses, internet, and many more. I identified myself as a woman sex worker, as a user of psychoactive drugs, and based on my experience, I've been able to identify the problems that surround the people that practice sex work, as well as the users of this type of substances. And there are just a few, or there are just no spaces in order for us to receive integral health services. Together, we also are people that are practicing sex work, and this has been stigmatized and discriminated by. So, of course, there are people, besides practicing sex work, we are a vulnerabilized group, besides also for using psychoactive drugs. So as I said, we don't have these services. Sometimes we're also stigmatized, even by the other organizations that deal or that work with this topic, and sometimes by institutions. So this is also the result of the lack of policies, of public policies and specific programs, and that are even efficient for this type of population. The care given to this population, the programs, most of the times they're just centralized on sexual, reproductive, and human rights services. Although they are vital or important and relevant for this, they do not cover all the needs for this population. We have moved forward, yes, but even though these services are not guaranteed, we are seen as part of a problem, but not as part of an effective response in order to cover the needs, the social needs that involve. It is relevant to have these integral health services. And when we speak about integral, we need to emphasize mental health as an effective strategy in order to reduce risks and damages. We need to think about on all those type of supports with legal issues, because many times we do not know. Many times we ignore what are the articles or what are the laws that we are facing, and we're being judged or we're being criminalized just by having a small amount of marijuana or any other substance. We also need to have a care with regards of our physical health, our dental health. Dental health is not included as a strategy. And we forget that this is part of the inclusion for food services. If these dental services are not covered for this type of population, of course there will be a lack in the food and the nutrition. And although sometimes we don't have good nutrition, by using these psychoactive drugs, of course, our health is diminished. Being able to share this information with our peers without a doubt, it's a very successful strategy, because we get to know each other. We get to know how can we cover all these services. We know exactly what are the substances that they are using and how they are using it, because what we need to focus on is on the use, on the problematic use of these substances, but not on banning them. Because, as you know, the banning of substances is implemented when the ARV treatments are being implemented. And sometimes for those people who live with HIV and use psychoactive drugs, makes them stop using or stop taking their medication because of the damage or the harm that it can create. So we need to visualize all these problems. We need to develop peer campaigns, and this is part of the effective response that has to be implemented among all the populations, not only with all those highly vulnerabilized populations, but from all the populations that represent this fight against HIV, because we need to focus on guaranteeing the services. Those people who live with HIV are vulnerable. They should have universal access to health services in order to receive treatment. Within the region, we are implementing a tool that it's called Suite. Within this tool, we approach 6 important topics. Among the important ones, it's to improve access to health services, to guarantee human rights respect, non-violence, to improve those places or areas where we perform our activities. And we are implementing this tool since 2017. We have good results from this tool in the 11 countries that platforms belong to. So we've been able to implement it with different governments, and in these boards, on the decision-making boards, we've been able also to create this awareness and to include sex work, not included as something that stigmatizes, because we are people, we are individuals, and being a sex worker doesn't exclude us to being an individual, to be a person. So if we stop labeling, and because, well, I understand that these labels are important in order to have access to these services, and in order to have access to the guarantees, and in order to have access to the funds, we should also be seen as individuals that belong to society. In Mexico, I just want to say that Mexico, of course, it has developed certain drugs policies, mainly for the recreative and medicinal use of drugs. However, these health policies are on process, and that leaves us in this middle space as the same of sex workers. As they are not banned or they are not criminalized, it's not been ruled, and they were just left in the middle, and in that sense, our vulnerability increases, and that leads us to this free violence. So that's why I invite you to see the people that use or that exercise sex work, to see them as individuals, as a network. It is important to participate in this type of fora, because it is important also to visualize that our participation is transversal, that we need to be included in the board committees in order to our experiences to be heard and that are relevant for our population. Just as a closing remark, I just want to invite you to see the sex work and to identify us as a transversal population, because this population is formed by all the rest of the populations, by all the genders, and we are in all the regions. We are individuals, and as I say, we shouldn't be left apart, or we shouldn't be violented. Violence shouldn't be practiced on us. Sometimes we do not feel in the requirements. Let's not forget that we are warriors, that we are in the line, and that we are a great team. We should have access to all the services from this free view perspective, free of labels that had been attached to our skin, and that the only thing that they guarantee is that we'll still live in anonymity as users. Many people that practice sex work are users of psychoactive drugs, and we do not disabilize ourselves because of fear of this stigma and discrimination, and because of that violence. So we as sex workers are not the problem. We are part of the effective response of the problems that are involved within these vulnerabilities. So I kindly invite everybody to include us in your working teams as an effective response. And I'm so grateful for the time offered, and we are free to answer any question when Rafael let us know. So thank you, everybody, and have an excellent evening. Thank you very much, Cynthia. Thank you for your perspective. Now we would like to continue with our colleague, Gisela Zambrano. Gisela, she is co-president of the Mexican Network of Harm Reduction, REDUMEX, and she has worked as health promoter as well as human rights of people who inject drugs in Ciudad Juárez from 12 years ago. Right now, she's working as volunteer in REDUMEX, carrying out the community record of those sobredosis events and distributing naloxone in spaces of heroin consumption.
Saludos, Gisela, ¿te encuentras?
Gisela, are you there? It seems that Gisela is not in the Zoom meeting, so let's move on with the next panelist as she's not available. Thank you very much. So let's move on. Let's go to Amaya. Amaya Ordorica Imas is coordinator of the incidence area of Reverdecer Colectivo, a youth organization that fosters a transformation in the current policy of drugs. She is now at the sociology at the School of Political Sciences at the National Autonomous University of Mexico. She performed as a researcher in human rights and drugs policy in the Mexican Commission of Defense and Promotion of Human Rights for 3 years, and she's co-author of the book El costo social de la guerra contra las drogas en México. The social cost of the war against drugs in Mexico, militarization and systematic vulnerization of human rights. She also belongs to the LANPUT, Latin American and the Caribbean network of people who use drugs. Thank you very much. I'm going to share my presentation. Let me know if you see it. Is it?
Bueno, pues justo como compartió Rafi.
As Rafi mentioned, my experience is based in the drugs politics, and I will speak in that sense, and hopefully this can be complemented with the participation of the rest of the panelists that so far have been really interesting. I would like to thank Rafi as well as the members of the conference and also the interpreters for being able to do this, to give this space. So, as Rafi said, I belong to this youth organization called Reverdecer Colectivo. We use psychoactive drugs, and we prefer to use this term because in general drugs it's ambiguous, and it involves a lot of many herbs, and it has a great stigma. So we're working on constructing this piece in Mexico. So the idea of this presentation is to speak about a little bit on how these drug policies are related with these social drivers. And in that sense, I would like to speak on what do we mean when we speak about drug policies. We refer to these actions, laws, and programs that cover the topic in different aspects. It includes regulation, it includes economic regulation, health, as well as social security and politics. In most of the countries in Latin America, these are the policies that are. These are the ones who have an emphasis in criminalization and in many senses militarization, and they are based in different systems that are banned. And I mention this because some of the plants and some of the substances are banned, whereas some others that are consumed on a daily basis, such as tobacco, coffee, sugar, cacao, and alcohol, all these herbs are also legal. So we have both schemes within these regulations. So what I want to mention is that on one hand, we have this social factor that because it impacts the equitable access for health services, but also they have an influence in some other factors, not only in health issues, but this is not a regulation that can be considered as a social factor as such. So in order to move on and to why this drug regulation is a social factor for health issues, well, because on one hand, these regulations had been built on this stigma narrative, and they demand and they ask people not to use these psychoactive drugs and herbs because the only approved service is to abstain from using them. So facing this, and some other colleagues that had already mentioned, such as Stacy, that it also impacts in the health services access too, because they demand to abstain from using them in order to access medical care. As they already mentioned, in order to get treatment for HIV and AIDS, and also for some other health services. And in some cases, this implies that they condition the access, let's say, for instance, for housing services for people living in the streets. So in that sense, this is impossible, and on the other hand, it is not necessarily what they want to do with their lives and with their bodies. As for here this is a contradiction, because in many cases, to abstain from consuming and using drugs, it is determined in order not to provide this access. So this might be that these are some of the we demand them that they need to cure themselves before offering the treatment. So this is like the great contradiction that we can see. On the other hand, we don't have these specialized health services. As Stacy mentioned, the relevance of these differentiated health services, they don't get that. Not only the users, but also the different levels of identity that we might have of we people, users of drugs. So on the other hand, it also promotes information based in myths, that this information that is mistakenly considered when people consume and they experience on a daily basis, they realize that this information is fake, and then they stop trusting those institutions that provide that information. So in that sense, this relation is being damaged. On the other hand, we have also stigmatization, and then that leads to school and labor marginalization, because they also lose social and family networks. On the other hand, we have the criminalization of users that in many cases it could become in police abuse, or they can go together with being incarcerated. And in Mexico, it could be to 3 to 25 years in prison, depending on the crime. And in Mexico also, this is delicate because these crimes are based in the amount of the possession. So let's say, for instance, that you have more than 5 kilos of marijuana, then you can be considered a drug trafficker. In that sense, they are not, they don't demonstrate any type of sale, distribution. They just demonstrate the possession of a specific amount of the plant. So this is a great concern, because it also opens the criminalization of users as well as of people devoted in a retail level. On the other hand, these policies also affect in this intersectional, these drug regulations are also fed by different factors that in its application, its classes is discriminatory and it's patriarchal also. Some of the examples had been mentioned previously as the ones that Cynthia and Stacy mentioned, and I think that Gisela can speak a little bit more. But the idea that deals on these illegal activities and then afterwards incarceration. So we see that the same stigma creates the path and these social determinants in order to comply with all this narrative in the laws, that all those people that are related are considered criminals, and in that sense avoiding the different options of working and earning money. And so we know also that people that are incarcerated do not have access to health services. On the other hand, we also have this denial of the services because of the consumption and use of drugs, and that not only impacts on denying the access, but the possibility that we have that option, and that in that sense we do not approach the services. And Stacy mentioned that. Stacy said, what are those factors that doesn't allow us to link with the health services? And I think that this is really, really fundamental. On the other hand, at least in Mexico, this narrative of the laws, we have these public enemies. So those people who are related with this type of drugs represent an enemy. We represent like an existential enemy of society, and we are responsible of all the violence. So in that sense, when something happened to us, men and women, they make us be responsible of our own violence that has been exercised against us. So these are not, these cases of violence are not being investigated. Just as a case of a massacre, this is something that has been complied with regularly in the last 10 years in our country. And if they were consuming drugs, of course, they were involved in something else. And in that sense, that's why they practice and they exercise violence. And there's no need to research and to sanction the responsibles in that sense. So in Mexico, the violence rates are a representation of the lack of access of health services. Not only torture, but also disappearance and homicides are direct impact in health as well as in lifestyles and life expectancy of people. So they get worse in women cases when we face this sexual violence mainly, and we are also users of psychoactive substances. We are criminalized and we are judged, and they make us being responsible in this fight. We also add the criminalization of people living in poverty and people, young people, trans women, and the relation that it is included within the state and these communities. That all these categories of people that are included in these levels, we can add also the use of plants or psychoactive substances. And in that sense, violence and criminalization against us is being justified within this narrative. And it is also colonial, and that implies in different cosmovisions in the region that we are living in, that have been built in hand with the consumption of these herbs and with this traditional ancestral use of these plants. So these policies have not been built following an individual logic or collective one, but we are not seen as individuals included in these social contexts. The use, this is like a moral fault. Even for instance, when we have this abuse on the use. So in that sense, these policies are not included that can impact and that can attend these health issues. Prevention is just being indicated in the idea of avoiding the consume, but they do not recognize this consumption, and even the United Nations recognize that nearly 90% of those who use plants and psychoactive substances do not develop any abuse or dependency situation. And in that sense, we do not create any preventive measures based on these social determinants that impact in the development of these problems. On the other hand, also public treatment offered do not cover these social determinants. This private treatment, it's not well supervised. They torture and they give this bad behavior, even if we're speaking about really very expensive centers that just a few can have access to. And also having abstinence as an objective represents an individual approach, and it is not indicated. It is not included as an indicator of communitary well-being. We need to move into several or different determinants that can include community integration, and finally, these security policies to fight those who sell and produce psychoactive drugs, at least in this social discourse, have a great impact in health matters as well as in other rights. In Mexico, at least we have 300,000 people living in these displacements due to the violence coming from these policies. And they are also facing more complex situations in order to have access to health services. So that's why that I wanted to mention a little bit the idea of reducing harm, of these harm reduction ideas that are related with these social determinants. And basically, harm reduction is this perspective that can be considered the foundations in order to implement, design policies, tools, services, as for consumption of drugs, as well as on other topics that are related. It starts on recognizing that they exist, and with some proper interventions, we can reduce these harms and these risks. We can have like this, each experience of consumption are affected by the person, the context, and the substance itself. So that's what we need to include within the center of this approach for health policies. They should have the approach to harm reduction. However, the ones that we have in this banning model creates more harm reduction issues. So what do we do in that sense? Well, we have started from the civil society organizations. We support each other as a collective through the networks. And here I mentioned the network of Enlaces Nacionales. So these are a network of disappeared people, and among many of the activities that they carried out, they give emotional follow-up among peers, which is really important in order to sustain these networks. Also, we've been able to see the impact in health in those who are looking for their family members that are disappeared. We have seen that high levels of blood pressure are increased, but we also have the lack of calcium, and we have many cases of cancer because the immunitary system is really depressed. So in that sense, cuddling and taking care of them is fundamental. We also have these self-managed programs, such as the programs of analysis of different substances that are carried out in the region. We also do that in Mexico, but we also have this naloxone, the exchange of needles, and the space of safe consumption places. Those areas are self-managed in order to create these services, tools, and services for health issues. There are some other programs of popular education, as well as to share information created by civil society organizations. And in example, we can mention energy control, AirWeed, and many more. We develop flyers, we provide workshops, we go together with the individuals, and in that sense, we provide these popular education services. And finally, the relevance of making to do it by using this, we run several, I can mention several exercises as a national, regional level, and most of the panelists here are also part of these efforts, and that make us be more solid so we can have these incidents in these policies, and done through this diagnosis developed from the bottom and from the people that are living this, facing these impacts. So thank you very much for giving me this space.
Muchas gracias, Amaya. Excelente como siempre. Ahora sí, entiendo que tenemos a Gisela ya con nosotros nuevamente.
I think Gisela is here now with us. Gisela Zambrano is co-president of the Mexican Network of Harm Reduction, REDUMEX for its acronym in Spanish, and she has worked as a health promoter and of human rights of people that inject drugs in Ciudad Juárez since 12 years back. In this moment, she works as a volunteer in REDUMEX, carrying out this community record of these sobredosis events and distributing naloxone. She's also a member of LANPUT, the Latin American network of users of drugs. Gisela, you have now the floor. The microphone is yours.
Saludos, Gisela. Si me escuchas, tienes la palabra. Por favor, darle a mute para que puedas entrar.
Just click on mute so we can hear you. Can you hear me?
Ahora sí te escuchamos.
Now we can hear you. I was just, I represent the Mexican Network of Harm Reduction. It is formed by people who consume drugs, and what we're trying to work on is to support people that are facing. Right now we don't have like materials, so I'm developing so my work as a volunteer is just offering this message that they can get these materials. So they don't leave this violence. So they don't use other methods. So they can have enough tools, and they can convey the message that they don't do it in any place, because in that sense that also creates, they will face these vulnerabilities. What we need is this public policy on harm reduction that allows these comprehensive health services for those who consume and use drugs, and for those also who experience being marginalized. That are more vulnerable and that they don't have access to receive treatment because they need to pay, let's say, 8 pesos for the bus, and maybe that's not expensive, but for them it's a lot of money. 8 pesos represents a lot for them. So that's one of the barriers that they are facing as women users of drugs. Because if they consume drugs, they don't receive treatment. So from both sides, they should say, we need to define the different method, and then we need to provide and we need to offer this follow-up companionship. Everything is comprehensive. It is not only the idea that you go to see the doctor and then they give you the HIV treatment. You need to also to go to psychological therapy or with the social worker. And many of these women are really criticized because they say that they are not really interested in their own health. And the thing is that they are afraid. They feel this fear from the center. They feel this fear from moving and going to the center, as well as from to the center where they receive the training. It's far away from their homes, and it's fear to that. It's fear also towards the idea that they do not have documents. One person that comes to my mind is Angela, and she's named because she said that she was born in the day of the angels, of the Angelas, so that's why she got that name. Some of them, they come from other states and it is difficult for them to commute, and this is a situation where the number of migrant people that move, and we also face this disease, and they stayed here in this area working as sex workers, and some others they got involved in drug trafficking. So I've been working in this Compañeros program for 12 years now, and also I had to give this companionship to people with HIV. The idea is to have less barriers so they can get health services. We can speak about many barriers that we face. Methadone is not given freely. If they want to support them, if they want to provide this support, I know that the government has more money and that they can contribute, because in a year we are spending 28,000 millions pesos in methadone. So why not to support them? Why not to support people with HIV so they don't stop taking care of them? So in that sense, people will have the benefit. They will get the benefit being able to work, let's say, in a maquila industry, and they can be productive. They can also give results in the work that they are laboring. That's the only thing that they need. The idea is to get rid of those barriers. Another task that I'm developing in the harm reduction network, we need to record these overdoses. We don't have like this counting, and if we do not document, then they say that it doesn't exist. With regards of women health issues, for women that inject drugs, they have the right that if they want to have a baby, doctors shouldn't. There was one case of one woman that didn't want to go into surgery, and here in Ciudad Juarez, we face the situation that the opinion of a drug user is not taken into consideration. So every Tuesday and Thursday they come, and when they go to the center or when they go to get their services, they will have like a better attention, because as they see you, they treat you. So not all the time we go with them, because there was one other person that I took there to the center, and then they say they reported that she said, "You don't know exactly what I have." So the idea is to get rid of those barriers. The idea is to have doctors and nurses that are trained, because right now we see that there's a high percentage of people that are dying because of hepatitis C. When they run the HIV test and HIV-C, they said that it's good, I have a good result, but they don't even know, they don't even care about hepatitis C. So that's why we need to develop these political incidences to make it clear that it is not only that they are not only left aside, that this is something that the government has to consider, because we're not asking anything. We have the right to have these comprehensive health services and of quality, of course. Another topic that it's been discussed is that they are using women. They wanted to take money. People with HIV are just giving this bad treatment. They just isolate them, and there's a lot of discrimination in these regards. Women, for instance, they just bring their children. We can say that they are using their kids, let's say around 7 or 8 years old, and they are just working, and they know because they ask them to do so. And this is a great barrier for when police arrive. They are just identified in the records that they live with HIV, and then in that sense police officers do not get closer to them. So as with this case of this new disease, there were 4 police officers who died, and they died, and they just arrived to these shooting galleries, and then they started coughing, and one of them died because of COVID. And then he said that yes, that he was positive to COVID, and then they just wanted to take him away. With regards of the women topic, this is what we want, that there's more we need to have more incidents in all that sense that within all the expenses from the government, they should implement these rehab centers, because in that sense that would be really difficult because of the condition that we are facing right now. It would be difficult for them to go to these rehab centers. The important thing here is that we just channel them, we just ask them to which center you would like to go. We cannot tell them this is the good one or this is not the good one. So we just offer them the options to choose. I will read now a story of a woman. Every day she visits my home and she says to me, I don't care if I die, and if they know that I live with HIV, why they are asking for my needle? Would they like to die? Or maybe they don't think that one shared needle will make them have HIV. I want to share this because I don't want them to blame me when they do the test and they become positive to HIV. Me and my partner, I've told him that I live with HIV and we always use new needles. So this is something that I say to them, that I'm infected and that they can use the needles, cleaning them with chlorine. So there are so many people live in this situation that they don't care. They don't care about their health. They don't care. They need to have more companionship. They need to have more follow-up, because, well, the thing is that right now we don't have centers. There are no NGOs that work with this topic. Only just a few colleagues that speak about access. And women with HIV, it is not only the problem of living with HIV, but also they have some other issues, health issues mainly, such as diabetes, or they have high blood pressure, or any other type of diseases. So most of the time they haven't done any pap smears, and it is important to give this companionship and to offer follow-up. We need to recognize and we need to give them this for those who have the virus and that are facing these problems. In that sense, that's why I'm saying that we need to offer these comprehensive services, because you are receiving the treatment and all of this, and then you need to take care of you. When maybe they just wanted to have something to eat, or maybe they just went there to get new needles or to get condoms. So that's why we need to document what it is done, because if we do not document what's going on, then they say it doesn't exist, and then it will continue on and on. We don't know exactly how many women die because of having this overdoses, or how many people are living with HIV. These are my requests. Another barrier that we are facing is society itself. Society itself is, I'm speaking about police officers, we have our family, and many more that they also need the support. They also need this companionship. And they also need to have accurate information. They need to inform their family members. They need to inform the relatives that it is not that they cannot get infected or that it is not contagious just because of sharing the pan. I mean, it has to be clear for them. Some of the other things is that women are marginalized, are vulnerable to this. Because women are considered an object just to get money or just to get the drug. And now they say that if you love me, let's create this, or let's make use of the kids to obtain more. So this is what we want. We demand equality health service, equality care. We also need accurate and updated information. Where in a specific year so many people died. No, we don't need that. We need updated information. With those figures, then we can know exactly how many people died in 1 year and how many more are still dying and what's going on. So that's what we will request our authorities with regards of all these topics and issues. I don't know if there's any question. Thank you so much, Gisela. Thank you for the time and for the space.
Sí, gracias, Gisela. La pregunta la vamos a estar tomando.
Gisela, questions will be taken at the end.
Muchas gracias por tu ponencia y por tu trabajo.
Thank you for your lecture and for your work and time. Now I will give the floor to Naike Ledan. She's a social justice and feminist protector with more than 15 years of experience in human rights, justice of the environment, food security, and socioeconomic security, as well as with the training of civil society. Naike has worked in Canada, Western Africa, and Haiti in the social change focused on civil rights and determining socials of this oppression. She's also known as creating spaces for those who had not been listened instead of speaking on their behalf. Currently, she's country director for housing work in Haiti. In this position, she fights for the social change in order to assure that people with HIV and AIDS in Haiti are respected with humane dignity in this context of discrimination towards LGBTQ communities and people who practice sex work. Hello, everybody. So my name is Naike, Director of Housing Works in Haiti. Most of the activities that I do is to give this empowerment to these base community organizations and to create this defense section with regards of health issues towards HIV. In Haiti, it's a very special case as well as the others. Many other countries are also special, but particularly in Haiti, we see that we have in these versions of top level that they go directly to these implementing organizations, that go directly to those organizations that plan and program the health responses, and in some cases they are not well adapted. Hold on a second. The national program becomes a medication distribution mainly from one unique government, and it's a generous government. And then, yes, I like to use sarcasm, but Haiti doesn't have this autonomy with regards of health management. Haiti is totally dependent of PEPFAR as well as from the Global Fund. It becomes a program that doesn't consider the needs of people as well as the needs of the health sector. When we speak about HIV, it is HIV regardless the other indicators, regardless the other related indicators. And in that sense, people avoid services. There is no any framework that considers these social determinants on health issues. For instance, when someone has to travel 30 minutes to move and to go to the clinic center 2 months ago, every 2 months, they don't even have money to give food to their kids. They need to prioritize. So when a female gay man or when a trans woman or when a very poor person goes to a place that is not well equipped in order to receive them in a proactive way, they don't want to commit themselves as for the space and the effort. So when we speak about these populations, I'm not speaking about key populations. This is my policy, because here I want to remark what we're speaking about. I will speak about poor person, a trans person, a homosexual person, because I understand that these labeling or these categories represent a capitalist violence. And I don't know how to say this, but they represent a division. This labeling divides population, those who are oppressed and those who are privileged. And this is very, very clear. The reason this is very clear, and that's why I don't speak about key populations, because it is very easy to name them, or it is really easy to label them, giving them a name that is not related with violence on what we are living on a daily basis. So that's why it's really important to clarify why I not use this term of key population. So Haiti is a really beautiful place, a beautiful country in many cases. In many cases, Haiti has these spaces. It is not what Trump said, but I should say that because and due to capitalism and patriarchal systems, we can say that this is a collective space where people, and I belong to that collective space, people go there through what we can call a social and economic anxiety, and that this is a very acute anxiety, and that can be translated into social reactions that are really complicated. And those are stigma, inequalities, and strange power dynamics between these oppressed people and between these privileged people. Those who care become privileged, and those who decide the oppressed. So then imagine the catastrophe that we are facing with regards of the ethics on the health services. Because these social determinants, the framework of these social determinants from UNAIDS were only decided as words, the national programs, the programs between the local and national responses. The HIV response replicates the same oppression and privilege frameworks that are promoted by society in general, because these are not programmatic guidelines that will revolutionize the response. They are just not including them. I would like to ask Rafi or Carla if you can show the cascades to illustrate what I'm speaking. Yes, please.
La página 2, por favor.
Slide 2.
No, antes, cero, la cascada nacional, página 2.
Slide 2.
Sí, ok. Sí, muchas gracias, Carla.
Thank you very much, Carla. In 2019, we have FQ1, and that is January.
It disappeared.
I don't see the slides.
Carla.
Sí, problemas técnicos. Vuelvo y la presento inmediatamente.
Ok. Yo tengo como la cascada nacional.
I just see the national cascade. I just see the percentages, the estimations. So the estimated figures, 2019. This is the estimated number of people with HIV in Haiti. This is like 160,000 people. And so this includes the approach that they use is that they don't include the person in the center. Only 84 of this figure is only 84% know about their status. Only 130,000 know about this, just to illustrate this catastrophe. And it is the third. And then on the third cascade, you can see we have 7,000 or 8,000 people. No, sorry, these figures are wrong. The third figure, the third cascade shows that we have 100,000 people that take their medication and that are really committed for their care services. So that is to say that we have 30,000 people that do not receive their medication in Haiti. And then in the next, only 8,240 have they were only the 8,000, around 8,000 people were only tested, and from them only 60,250 have their viral load suppressed. So it is, that only represents the 48% of people with HIV in Haiti who had a viral load. And there's a great amount of money that the government gives in general to the response. Can you show slide 6? That shows the reasons why people. These are the reasons who are lost to give a follow-up. These are the reasons why they don't get follow-up. I'm so sorry for my Spanish, it's not so good. These are the reasons. The first one is because of their occupation. The second one is poverty. And there are so many more reasons, but it is clear that, well, if we analyze all these reasons why the main reason is because there's no program. There's not a program that includes the customer at the center, and they don't include also these social determinants as for health issues.
Saludos, gracias Naike por la presentación y gracias por tu esfuerzo y por dejarnos claro.
Thank you, Naike, for your effort and for giving us the clear ideas in order to close this panel. So now we're going to take some of the questions. Before that, I would like to ask the panelists if they can give us like a final idea. Speaking about activism, we have discussed about the social determinants and how they affect to those populations, not key populations, but in general, populations vulnerable by society. So we're looking to have an answer, to have a response on how to move forward and how to move aside from this, creating this social movement. So Charles, can you speak about this activism and how can we change our difficult frameworks and contexts? Yes, the reason why I spoke about the decision-making process on the concepts of UNAIDS and the political declaration of the General Assembly of the United Nations in the last meeting of high level is because I think that they are permanent. They are permanent. And we should take advantage. We should take advantage of all these opportunities. So all the governments co-funded by UNAIDS, asking them how they are fulfilling with these commitments, how they are complying with them when they don't have a good response towards them. So we need to use this response in order to demand action and also to make them responsible, to make them reliable. We can offer this token, but only when they commit themselves to take this seriously. Thank you, Charles. Some of the other panelists would like to speak about how we see activism and how we give this light or this anchor to how we can move on our daily basis and from our collective centers when we develop this activism or this fight.
I can say I switched to English. I think I've given all inside of my insight. I can say that it's important for the right, very important for the right people to be in position to speak for themselves. And it's very, I see in Haiti, for example, it's very, very, very easy when there's like a room full of of people in position of power, or people that are experts, or that, which is power, like, a privileged man, people with that have access to vocabulary and knowledge and sound a certain way, to take over spaces where an answer is designed, where evaluation of a program is discussed, for status quo to stay the same, until we start disturbing the public space and putting people in these spaces that they, like, people that don't know what they're talking about will not dare talk about this stuff, because actually people living with HIV, trans women, people that are living in vulnerabilized situations, that in violent situations, will say, no, you can't talk about this because you don't know what you're talking about. You've been doing this for 10, 15 years and you're making a shit tons of money and speaking your rhetoric, and nothing is changing. So until we actually, as activists, use the power that we have to open up space for people to speak for themselves, I think this is actually, one of the most path of integrity that I believe in, because it has the power to really change space, instead of thinking that we can always speak for others, no matter how good intention we have. I think this is maybe definitely one step, if I can contribute to this space.
Gracias. Pues cómo ser contestatario y tomar espacio, no solamente en representación a.
The idea is to be activists and to make them participate from those who have been affected directly. So Cynthia, something else? If not, then we move forward to the Q&A section.
Hola, perdón.
Sorry for that. I have problems with internet. Internet is a great challenge. Can you hear me?
Hola.
Sí, te escuchamos,
Stacy.
Yes, we can hear you.
Quería sumar.
I just wanted to add that the life expectancy in Latin America is of 35 years of trans women. So this is a general average, but in some other countries it's lower. In El Salvador, the life expectancy is 30, in Guatemala also. And our in the community, those who die from HIV, they don't go far from 30 years also. I can say that this is one of the main determinants that we need to pay attention to it, because also speaking about childhood and speaking about the teenage years of the trans population, one of the objectives and one of the early activisms is that new generations don't face what we faced or what we had lived. And I want to say that I want to convey in this conference, and I kindly ask you to think about and to make this reflection for these new generations. They should develop a new type of activism, not the same activism that we've been doing with all these situations. So when our life is in danger, we should pay more attention to those social determinants and to work on that, because some of the situations that we also face is that from civil society, from these cooperation aspects, and from the governments and from the states, we don't have this intersectionality. There's not a real intersectionality that cross-cut all these situations and that we can create this liaison. There's a lot more to do, but I think that as a trans woman from my fight and from the fight of all my colleagues, we are really convinced that this is the future is trans and trans feminist.
Gracias, Stacy. Carla, ¿tenemos alguna pregunta?
Any question?
Tengamos que responder. Nos quedan
Any other
segundos.
questions?
Podemos atender si hay alguna pregunta.
Sí.
No se ha atendido.
Sí, saludos.
Yes,
Josué Quino pregunta,
Josué Quino is
¿qué
asking
pasa
to
con las
Stacy,
mujeres
what
trans
happens
después de
to
los
the
35 años? Nunca
trans
he
woman
entendido
after
eso.
35 years? He doesn't understand that. What
Sí, Stacy,
happens?
¿podrías darle mayor
If
información?
Stacy, if
Porque
you
las
can
mujeres
give us
trans
more information, if you
llegan
can,
hasta los 35
why
años.
they reach 35 years old, and then
Sí, vamos a hacer otras preguntas y después contestamos o de una vez.
Rafa,
should I answer?
Puedes contestarle ahora.
You can answer now. We just opened the Q&A session,
La compañera, voy a dejar que hable la compañera.
but I think that someone else is trying to speak.
Se
Gisela?
escucha, Gisela.
ok, gracias.
Yes, Gisela.
Lo que quería decir es breve.
I just want to say that we have the need to have this public policy, harm reduction public policy in here in Mexico, and something else that I wanted to share briefly is what we are doing as activists in order to create that change that we need. As a harm reduction network, we participate in different spaces organized by the government in order to give this visibility to those problems that women who inject drugs face. Giving this empowerment through this companionship on a daily basis. So when we do that by raising our voice when these injustices are committed, we speak about the projects of those records from those people who died because of sobredosis, because these cases are not reported by the government. Another activity that we do is that we document the challenge. The challenge is the lack of funds, the lack of financing from the federal government. We do not receive any type of financing, and without that, we won't be able to support many people that trust us and that they don't receive any care from hospitals. So those were my final comments.
Gracias, Gisela.
My last comments.
Stacy.
Thank you, Gisela.
Sí,
Stacy.
¿qué pasa con las mujeres trans que pasan los 35 años?
So what happens with the trans women after 35 years old? Well, they continue practicing sex work and they are abandoned women. They are more vulnerable. They become more vulnerable women. And I say that because it is not the same that a young woman practices sex work as a different from an adult woman. There's a huge gap within these vulnerabilities that are there, that are tangible, but it is very difficult to reach. There's an exercise that older women, and a good practice is this comprehensive law from Uruguay. This comprehensive law from Uruguay compensates those older women of 60 years old and that also that are also practicing sex work. In this sense, this is an issue. This becomes an issue because your childhood, your teenage years, and your youth were taken away, and now they are also taking away your elderly years. So in that sense, I think that this is something that we need, that has to be compensated, and that has to be and that has to be taken care of by themselves. Or sometimes elderly trans women die alone. Sometimes they die alone in hospitals or in their own homes, not knowing exactly what's going on. In the region, there's only one program, and that's a program held in Mexico City. So imagine from 35 countries of the country members in this Latin American and the Caribbean network, that is only one country where there is a law, and there's only one country where there is one program, and then it's not a state program, but it's a program run by civil society. So there's a lot more to work and to do for this elderly population. And besides that, you reach these old ages without having education, without having a family, without having housing services. And let's not speak about the partner issues. Sometimes it happens that their partners had left them without nothing. And this is also related on how they take care of their bodies. And in that sense, it is really difficult from the trans women community to speak about these social determinants in health issues, when these determinants do not come from our anthropological dynamics, but they come from social dynamics where dogmatism prevails more than some other aspects, such as protecting and taking care of human rights of people. And in that sense, what they do is that they label you, and by labeling you, they take out your human rights. So let's see when we stop being trans women and we become citizens that can exercise their own rights. So there's no more time left. I just want to ask Cynthia or Amaya if they have some last comments to close. I would like to thank everybody for attending this panel. Thank you very much, Rafael. Thank you much, everybody. Nike, thank you very much for giving this visibility and mentioning that we are also individuals and that segregation is not an effective response. The discourse of Griselda mentioned that we need to work among peers, and we need to train our new leadership. We need to continue. We need to empower them in order to create this incidence or this impact in public policies. And of course, we need to emphasize that we need to work together in social communion for this criminalization of the use of substances and to legalize them, as well as sex work. We need to work in order to involve those involved in these effective responses. So thank you very much to all the attendees, and thank you for your participation here. Thank you very much, Cynthia. Amaya, I just want to thank all those involved in this panel. It was really interesting, Rafi, and also the organizers. Just to remark, something that we take from this discussion is the relevance that we can cross-cut these fights, and then that we should recognize the intersectionality of all the vulnerabilities that we shared, and we need to highlight the vulnerabilities of these identities and all the topics that implied with these social determinants. It was an honor to participate in this session, and have a nice day. Thank you very much. So thank you to all the panelists. Thank you for their participation and contribution in this session, and have an excellent day.